Sorry for the technical problem happened, and right. So it's the admission, and this is a example of a admission sheet, right? Nowadays there's a standard admission sheet which carries all details, but I wonder whether we all are ready to follow this. Most of the time, what we have observed is it is not done. So this is just an example which was used some time back when I was at Nikkavarati Hospital, and here are some examples, right? In this admitting doctor has done a fairly acceptable job. He has done a good thing, and here's another one. Admitted as requested, right? Blank. Nobody knows whether this requested admission is a dead patient or live patient, right? Sometimes the corpse can be admitted like this because nothing written. This is the second sheet which is specific to the hospital. This is from Gampola Hospital. Again, just see the first page. It's like this, the medical documentation by an admitting doctor. Another few examples. Admitted as requested, that's all. It's also not written, just a stamp. Anybody can do this, right? Somebody who is in the OPD, even a minor staff person can write the names and these things and put up this seal and send the patient. Nobody has taken a responsibility other than a small circle there. This is the responsible person, right? Clerking. When the patient comes to the ward from the OPD, still you have to re-identify the patient. Why? We may mix up the patients, right? Because there may be about 10 admissions and the BHTs are there. Somebody will come and sit in front of you. You just ask and go ahead with the clerking and never cross-check. Sometimes you may mess up the patients and the wrong patient will get a wrong treatment, wrong documentation. At last, when something goes wrong, who is responsible? The doctor who did the documentation. So always you identify the patient in the ward before you. That's how we learn. Name, age, and the gender, then to proceed. That's how we are taught to write the history. But we forget that basics. So always do that, and as a habit, what I do is I just ask the patient full name. Tell me the full name. Even if he hasn't given his name in the during the admission, still if you ask the full name, you can proceed with that because that's how the patient identified himself to us. There's no problems. Right? So need to do the descriptive clerking, and record should be within the documentation area. Otherwise, it is not legally accepted. I'll show some examples. The blue pen is for documentation, not a black pen. Right? The red pen is for important events and nurses' markings. We have some examples for that. And the black pen for specialist notes. There are some norms, accepted norms internationally. Certain colors are for certain categories. For example, the violet pens. Violet color is used by the auditors, right? Like that, there are certain given colors for those documentation. So it's usually the blue, and black color is for the specialist notes. So the name and the identification code of the doctor who see this patient or clerk this patient, right? So you have to take the responsibility. This is me. So if you write SHO, which SHO? You have to sign and you have to write your name, right? At least some kind of code. In other countries, some of our consultants and some junior doctors might have worked in the abroad places, and there we do have some code number, right? When I was in abroad, my code number was 3402. So whatever the documentation goes under that number, everybody in the hospital can trace me. It's my document. I have to take the responsibility. Whatever things we have done, I can access the hospital system after using that code only. Then only the documentation is open. Then I have to write it in the documentation, right? So it's like that. So at least we have to have a practice that take the responsibility by writing your name, right? So the nursing notes, unfortunately in our setup, only in the ICU we use practice this. So nursing notes should be in a separate set of notes, separate BHT for them. Right. So these are some examples, right? Right. So comparison, 0 to good, nothing here. This is the word clerking. Just see, it's a little bit blurred. He has written only RTA. That's the clerking of the doctor, RTA. What kind of RTA? What has happened? Nothing is there. But this doctor had some decent writing there. Here, he has bothered to fill at least some cages. So this is the back page of that clerking. RTA, this only. They have done some kind of descriptive clerking here. They are better than the other two. So at least try to go to this same. This is not acceptable. Right. Just a simple example. When I was a very junior level at Kegol Hospital in the ETU, there were some two adamant doctors. Unfortunately, they were there in the lunch time, and no X-rays and everything. As we know, the surgical SHO also usually don't come. And unfortunately, there was a young person, 22-year-old boy, who brought to the ETU after a fall from a tree. And these two doctors were there. They didn't see the patient, no clerking at all, right? So before 2 o'clock, that patient died in the ETU. Right? So after this death, it was there was a big problem in the hospital, and there was an inquiry. During the inquiry, when they took this PHT, the clerking was fall from height, BP 120 by 80, pulse rate 72, abdomen soft. That's all, right? Saline, informed surgical SHO. That was the clerking for 2 hours. During the inquiry, when they were asked, X-ray technician came and told, if we are called, we come usually. For any emergency, we come and do. The surgical SHO told, if they told me there is an emergency, I could have come and seen. They didn't tell me. Right? So this type of clerking is causing these type of problems. Right? So they were harassed by the team who came for the preliminary inquiry. Doctor, is this what you are going to write? So as I told, the documentation should be in this area, which is meant for documentation, not here, not here. Some examples, and this is not acceptable, right? If this is produced at the courts, they just take off these things. They think that you have added it later. So safe thing is to keep some little bit of gap when you are clerking. So whatever the things you may do something and you forget to document it, so you can enter it, right? Don't cheat, be frank, and you can cover up your mistakes. What is this? What is this? Hassan? Huh? Quarterly temperature chart. Anybody else? Some senior? We all see this every day, isn't it? What is this? Anybody knows? Have you gone through this chart? This is the observation chart, right? Go to the board, take it and see what is there. Sorry, the temperature here, lot of things here, and it carries the pulse rate and lot of things here, the observation chart. This is a preliminary observation chart which is to be used in the boards. We think it's a temperature chart, not only the temperature, pulse rate, blood pressure, urine output, and several things. Unfortunately, this is old one, so it doesn't carry the SaO2. It is so. It's like for the HDU care. So we all don't know, after practicing years and years in the hospitals, what is this? It's very pathetic, right? No, don't bother. Everywhere the answer was temperature chart. So that's how it is. So there's a anybody aware of this? There's a circular issued by the Ministry of Health, guidelines for the documentation is the BHT. Anybody knows? It's in our ministry website, right? So there's a guideline for this. So it's very easy. Go for the planning section. They have done all the hard work and put up it there, and nobody bothers to see. Unfortunately, for some reason, I don't know, these are sent to the hospitals, and it was not conveyed to the doctors. So anybody aware? No. So there's some problem, communication problem within us, right? Within our community, right? So that's the doctor's problem, because the planning section, there are also doctors are there, we are here, and this communication gap is there. So clinic notes, some funny things we can see in the clinic books, right? Book should be owned by someone with registered number, right? And for the continuation even, you need to have a summary in the of the previous book in the new book, right? So this is a clinic book. It's well written, the name, address and the number, and which hospital, which clinic. In this hospital they have a color code. In our hospital also we have, I think, different books for the different clinics, it seems. So it's a good thing, and number, name, everything is there. But unfortunately, this clinic book, from one medical clinic, it seems, and a ghost owned this book. Anybody can take this book and take this book. No number, no name, nothing. Just write the. Is it a responsible way? No, it's our responsibility to write this, right? Not the nurses, right? This is a funny thing. One patient came to my clinic carrying 1, 2, 3, 4, 5, 6. A new referral given from the. He had 5 registrations in the surgical clinic, same surgical clinic, within 1 year. No, within 3 years, right? These are clinic notes. You can see that the doctor has bothered to do some more clerking and do things good, right? This is how a clinic book should be, right? Another one, and diagnose. There was some. Right. I had some pictures with the which I don't want to post it. For 4 pages, date. They didn't bother to write even a continuous same, right? CTS was also not written. Just the date only. So very pathetic, right? And that patient told me, "Sir, I was never checked with the blood pressure. That doctor didn't touch me, and he didn't ask anything from me. This is given with the date only. They are taking the drugs. I don't know how. Right? So the diagnosis card and discharge notes. It's a patient's right to have and the doctor's responsibility to give. Even if the patient fights with that and go away, still you have to give a diagnosis card. For the transfers also, if you transfer a patient from one station to the other station, it's a good thing, good practice to give a diagnosis card for the hospital stay with us, because now he is going to be a new patient to a new hospital, right? So for the claim purposes, other things, leave things and everything, he may need this card. So we have to give it. Later we are also in a trouble. We have to trace that ticket and this and that and do several things to overcome these problems. Right? So details notes should be given, not right, but it should not be a copy of the BHT. Sorry. It should carry the relevant summary of illness, summary, investigations and procedures done, because to prevent that duplication, investigations are very important for the patient, right? Further plan of care and instructions to the patient and the relevant unit or consultant who gave the care. Okay? So sometimes we see the cards, don't know from which hospital, under whose care, and the patient carries a card, right? It's a little bit funny. So the problem with the doctor who writes this card, and it's his responsibility to give a complete card. Don't just scribble something and just let the nurses to give it. It's your responsibility to talk to the patient and give it and explain the things there. Even if the patient goes against medical advice, right? We have to give it, but we have to document. This patient goes against medical advice. Don't write llama. Llama is an animal who lives in Andes, right? Or the somebody will think that the patient is a follower of Dalai Lama, right? So it's not llama. It's clearly write it, because if the patient is going to produce it anywhere, patient is in the losing side, yeah, we are in the winning side, because it clearly says that patient went against medical advice, then he does not have any right to fight back. So you are safe, right? For your safety, write it clearly. Right? Even if the or the transfer to other unit, right? So these are some specimen cards in this card. It is little bit descriptive, but nowhere it is written that from which hospital it is, right? This one, this is a real life one. I crossed it because it carried some unwanted things, right? Somehow they managed to write a little bit acceptable card. This is a bad practice, I think. When they go home, 1, 2, 3, 4 to continue, right? Why can't you write the drugs? So the patient will go home and keep on counting 1, 2, 3, 4, 1, 2, 3, 4. Right. This diagnosis card, right? So it is the problem is for the same admission, patient carry 2 diagnosis cards. How can it be? Either the same HOD has written 2 cards, or 2 households have written a diagnosis card each for the same patient. So somehow patient went home with 2 diagnosis cards for 1 admission, right? Which can't be. It's a single document, right? This one, fairly a good one. They have written a good summary here. After a right inguinal hernia, date, everything is filled, and right. This one is also fairly a good one. This card, something is scribbled EUA under local anesthesia, and only the name, no dates, nobody knows when was it done, which hospital, by whom, no responsibility, no date, right? Nobody knows whether it's in 1950s or 2000 or 2050, right? So unfortunately that patient was under me. It was Dr. V.R. Jayasinha who has done this EUA. Right? This I got this in the private sector, right? The next one is also that the epididymocarditis and hydrocele. So they have done a fairly good job, right? In that one. So there were some problems that the ciprofloxacin was given for only 3 days, which we used to practice to give longer duration, more than 7 days. Right? I usually give to 12 to 14 days because the ocarditis, sometimes it responds slowly. But it was given for 3 days. He has done a good job with the card, but management is not the proper thing. Another disaster, right? Can you see that? Blank card with a very important invasive investigation. I picked this in the at Nikavarattiya in the corridor, and when I saw it again, unfortunately, it's me. Right. From my side, a sigmoidoscopy was done. Right. Unlucky patient, nobody knows who it is. We couldn't trace, but it was luckily it was a normal sigmoidoscopy. The patient lost this, and we couldn't find the patient. Right. So this is what it is. Very irresponsible job. After doing all the hard work, get this patient make ready, get them admitted one day in the hospital, and did a very invasive procedure, and which carries a risk of bowel perforation, and still nothing really. Right? Just a 2-3 minutes job. Right. Another unfortunate thing again. Same patient carries 3 diagnosis cards for the same admission. When I inquired, one is for the VOG's referral, but nowhere it is seen. I took about 3 hours to find out what is this, and these 2 cards under my name again, right? So the patient brought it and asked, what should I do next? Because everything was written in even though the patient had to carry 2 cards, everything was written. Patient doesn't know what to do. The patient came to the private sector asking me, "Sir, what should I do hereafter?" Right? So the plan was there. No point. So anyway, the message is they can't have 3 diagnosis cards for the same admission. Right? Right. This one again. Right. There was a right leg diagnosis. Is investigated for right leg tibial fracture. Again, I was the culprit. Right. It's Vajra Jayasinha here. Right. Investigated for right side tibial fracture. I don't know. So, right. I had to call the all the animal names when I took this back to the ward. Right. Another one. Blank card with my stamp and something scribbled in the back page. Right. I think this is a bad practice with our junior doctors. They just take 3-4 cards to write this diagnosis card. First page they write something, then they take another card and write something again, attach all together, and they don't bother to cross this part even. Right? You can write. You need not to have 3-4 cards. It's a summary. If you have a long thing to write, just ask the patient to bring a book and write it, and give a summarized card. Diagnosis card is single note, 1 card. Right. This is another funny thing, right? Unfortunately, I have to point fingers on my VP colleagues. Most of the medical, I don't know why it is. So the junior's habit is to pick some kind of book with the patient. Sometimes it may be his children's school notebook. They write the diagnosis card in that book, right? In the surgical clinic book, medical, some other Ayurvedic practitioner's book, whatever it is, they write this card, right? So this is the surgical clinic card, which is owned by Dr. Hanisha Kamal's clinic, and the medical team has written the medical admission there. So just please look into these matters. It's not a good thing. Patient get lost. And second thing, they have done an unwanted thing in somebody else's clinic notes. Right? It's not authorized. So then patient get lost. They don't know what to do. They can't go to the proper clinic there. Right? So another one. No diagnosis, nothing, AF, PVP, LMP, EDD, G1, some abbreviations only, nothing there, right? All the abbreviation card, you can see, right? So abbreviation A, B, C, D, E, F, G, H, everything is there, but nobody knows what it is. So what is this? Is that medical documentation? No, everybody will laugh at you, right? Because diagnosis card is an international document which reflects your unit to the rest of the world, right? So these things are happening in the specialized units, like I'm not telling that BOPTS unit, but most of the time, orthopedic units, right? Eye units, then the cardiology units, and what I have seen, my experience, right? And specialized units like that, right? So it's a highly specialized management. Nobody can understand. The abbreviations are written, right? So it's very important record, but even as doctors, we can't understand what is there. Right? So how can we give the care to this patient? It's very unfortunate thing. So don't practice that. Keep abbreviations among you and within your unit, and just write a good diagnosis card. I know that they do all the hard work with this patient, orthopedic units, cardiology unit, and these neurology and neurosurgical units. So after keeping the patients for weeks and weeks, don't spend 5 minutes to write a proper card. Right. And the other funny thing is managers UTI. Right? That means you are not competent enough to come to a conclusion. You just අඹ ගහට ගල් ගහලා. හරි? වැටෙන අඹේ අහුල කියනවා. It's like that, no? Managers. Why managers? Either there's a diagnosis, or you don't have a diagnosis and you just investigate this patient for something. So write that. Patient is investigated for abdominal pain. Patient was investigated for fever. No conclusion. Problem sorted. So, right? So investigated for. Not managers. If it is a UTI, it's UTI. Right? Sometimes we find patients, they come with a severe abdominal pain. We don't know what it is. Investigations, we can't come to a conclusion, but when we give antibiotics, they resolve. So what we write is non-specific abdominal pain, investigated, responded to antibiotic. Only the God knows. Nobody knows what to do. Somehow patient get cured, right? So the message is there for the rest of the teams, right? So these are other things. The important things are written in the red, right? And next thing is that consent. Consent. සුදුසු නිර්වින්දන තත්ත්වයක් අතරේ ශල්‍ය කර්මයට කැමති. Right? Nobody knows which anesthesia is going to be given and what is the ශල්‍ය කර්මය. Patient doesn't know ශල්‍ය කර්මය. You can do whatever it is. You can behead the patient. Right? Right? So these sometimes I do good things as well. So this is also Vajra Jayasingha's clinic. The consent is taken as like that, right? This is a descriptive consenting. not to demonstrate, the team work with me and the anesthesia team knows that's our way. I have escaped from several occasions by writing a good descriptive consent, right? This is my handwriting. When you lead the way, this is how they follow. This is our house officers, right? They also do the descriptive consenting in the clinic book. So it's a safe thing to write the consenting in the clinic book. For the consent, again there's a circular. Anybody knows? And this is the format, Health Ministry format, which was published in 2017. We don't know. Has anybody seen? Robert? No, never. So it's there, but it doesn't come to the ground level, right? So no point of implying these things, no, if it doesn't carry the message. Right. Forms are not order forms. They are requests, right? Request forms. So we are requesting. We need to fill it in informatively and correctly. Patient's identification is the most important thing. Not to misidentify the patient. If you do the mistake, disaster. Right? Just one example. Right? One day I got one patient. She was seen by me in the private sector, and she came with a report. This one was a breast lump, right? So she gave me some name, some Padma Kumari something, and when I asked for a ultrasound scan, she had a ultrasound report stating that PK Samanlata, 48 years old, female with breast lump, ultrasound, blah blah blah, suspicious lesion, right? Then FNAC was requested. FNAC report was PKSK Herath, 48 years old, FNAC was suggested ductal carcinoma. The problem with our colleagues as well, because usually I used to write the name which was given to me by the patient, right? So I wrote that name. They have to issue the report for that particular request. I usually used to write that patients, at least 2 names which patients gives to me, and the age and everything. So be careful. Don't issue reports to the what they say. Right? Issue the report for the request. And when we request also, we have to request the proper name. So this is confusing. I refuse to do anything. I ask the patient to go back and get the report in one name, under one name. Otherwise I can't proceed, because I have to do a highly invasive, right, excision. And it's for a cancer patient, right, which I can't proceed for 3 reports under 3 names. Right? So patient has to spend some more. So this one was a request for ultrasound, right? Abdominal pain. Our radiologists are qualified, right? They are qualified after the evaluation of the board of studies in the College of Radiologists, and after a highly competitive exam and everything. They got through, and we know they are competent. So we should not test them again to test their knowledge. Right? Abdominal pain, this is like for the exam. Ultrasound scan. You give the proper history, then they can see what do we want. Right? This is what it is. Right? So this one was to be sent to the radiology department. I had to fill everything. Right? Short history, abdominal pain with low abdominal tenderness, query urinary in origin, these are the symptoms, and ultrasound abdomen. Then the radiologist knows what is there and what I am looking for. They can help us, right? We are asking for help from a colleague, right? So another one. This is a X-ray, request for the X-ray, right? Patient, there was a leg discrepancy, so we want to see the femur length and the tibia length. So we have asked for everything, and after writing in detail, and I wrote that this is to compare, this is to compare the bone length. Then the radiographer knows that he has to take whole length, and he knows how we take the measurements, so he will include all the points. Otherwise they will have upper part, lower part, where you can't take any bone length. Right? So it's a descriptive one, right? So it's also from our unit. Sometimes we do some good things as well, right? And this is a X-ray request, not acceptable, no enough details, and unfortunately second one they have done that. Nobody has requested this. Blank, right? It can't go to the. So the correction was done because the previous one they have asked for a cervical spine. Nobody knows which view. They can turn the patient like a spin and take X-rays. So we have to ask that AP and lateral view. This view what we want. Right? So this is another one. Right, pathology specimen. Again, they are testing the pathologist. It is the difficult read here. Something. Then, it's a wound. Right, specimen of a wide local excision. Here, wound. That's all. So then I had to write everything. The specimen mark. Right, which is lateral, which is superior fold, and what do we think? It's a suspicious of squamous cell carcinoma. So they know what to see. Right. Some more specimen forms here, and Snake has requested this one. Right. It was a snake. Right. Sometimes you same here, and unfortunately nobody has requested this. Right, and this one he has bothered to write everything and put this snake, but the lab people have to decide which investigation. The blood sample goes there for what? Nothing. Here, right? In this one also same. It was written. The most important part is blank, right? So you have to write a proper one. Here the full blood count and FBS, SGOT, PT, and they have written that liver full profile they need. So it is so. And everything is written properly. Patient's name, age, surgical clinic number, everything is there, but it doesn't carry in which surgical clinic, who is the responsible consultant. Nowhere it is written, and all the details are there. Nobody takes the responsibility here. Can you see? So you can't leave it. You have to write your name. Right? So these are the requests and the report for us. So when you request with a properly filled one, they will give a good report back. Right. So this is again from our clinic, pathology specimen. We requested an early report and wrote the history and what we want. Blood for blood picture, and this is the history. Right. So next one is for MRI scan, MRI abdomen. So I have written that I have discussed with the radiologist, and it's not confusing, and short summary and everything. So then it's easy for them. Right. The importance of these things, filling the request form properly. I found these two reports in a BHT with a full blood count. Right. One BHT, these two were attached when I rolled through. White cell count was 9,700 and other one was 16,800. Neutrophil count is a big difference. Hemoglobin also. So two different reports in the same BHT. When I checked that, it was date was same, 15th May, 9 a.m., 11 a.m. Within 2 hours, two different reports. How can it be? When we further checked it, PA Veerasinghe and PS Veerasinghe, BHT was two different things. Luckily, this house officer has written the BST correctly, but not the name. It's only Veerasinghe. So Veerasinghe's report came, they pasted it to Veerasinghe's ticket. Later only they also realized that there were two Veerasinghes in the world, P.K. Veerasinghe and T.S. Veerasinghe. So be careful, right? Because these two were in the same ticket, we just inquired about that. Otherwise, lot of mistakes will happen. Say now, if it's a dengue patient with low platelet count, you paste it there somebody else's ticket, what will happen? The person with the normal thing will survive, but the actual dengue patient will die. Right? Right. Transfer forms. They are only documents which receiving the receiving end will have. So we have to have a descriptive one. It should be well detailed, and patient identification should be properly done, and a good summary of the history and condition, and detailed summary of investigation. Better to send the investigation set with the form, right? Then the receiving end will have lot of information with that. And the important thing is the condition of the patient just before the transfer. It is the most important thing. We have to clearly write that, right? So these are some transfer forms, right? This is what I have written, and this form went with the patient without any more description. So luckily at the ambulance I checked it, so it was about to go. So then I took it and make all the summary and everything before the patient leave, right? So these are some specimen ones. I copied it because I can't took that one. Sent from the periphery, right? They didn't give any proper history and didn't ask why they sent the patient, right? This is another one from a periphery. Not sorry. This one was we send a patient to the neurosurgical unit, and they transfer back the patient with this small note, right? And can you see the retrans? Retrans is just another arrow. No, it should not be. You have to write a new transfer form, right? Teaching hospital somewhere, teaching hospital back to the same hospital. If this ambulance met with an accident or some problem, then everybody is in trouble. How can you take the patient back without another transfer form? Because he was admitted to that hospital for the CT scan and then transferred back, right? So it should be another form, not the arrow, right? Right. This is another one, right? This one was gone to Kandy Hospital from my unit. So I used to have a practice that I asked them to send a photo back to me of the transfer forms which are not correctly written. So this one was sent by Dr. Tilak Pereira, right? So blank one. It was from our unit, right? There's another one, by hand transfer form, right? Sorry. So lot of disturbances today. Anyway, that one was not a transfer form, even though they say it is a by hand transfer. It's a within the institution referral form, right, which you use as a diagnosis card. The small card, it's a referral note. It's not a diagnosis card or a transfer form.